All right, let's get right into it. We're heading out to the roadside, to the real sharp end of emergency medicine, where every single second counts. This is the world of pre-hospital trauma care, a field that's been, well, completely revolutionized by moving life-saving procedures out of the hospital and directly to the patient side. So why was this revolution so desperately needed? Well, it really all comes down to this number. See, back in 2007, a landmark report in the UK just dropped a bombshell. It found that 12.5%, that's 1 out of every 8 major trauma patients, was showing up to the hospital with their airway partly or even totally blocked. I mean, that's a massive failure in care, and it was all happening before they even got through the emergency room doors. You know, when the medical community saw that number, they knew things had to change, fundamentally. So the big question is, how on earth do you go from that 1 in 8 failure rate to safely pulling off something like anesthesia in the absolute toughest conditions you can think of? Well, that's exactly what we're going to unpack. Okay, first things first. You've got to picture the scene. This isn't your clean, perfectly lit, controlled operating room. Not even close. It is, and I mean this literally, a hostile environment. And this really drives the point home. Just look at the difference. In a hospital, everything's on your side. You've got great lighting, your team knows each other, it's safe, and you can get to the patient easily. But out there, at the roadside, it's the complete opposite, isn't it? You're fighting the dark, or maybe blinding sunlight. The person next to you, you might have just met them. There's traffic whizzing by, maybe a fire, and your patient could be stuck in a wreck, making it almost impossible to get to them. And that's not even the half of it. You've got weather to deal with, unbelievable noise, just pure chaos and stress. And yeah, sometimes the public isn't exactly helping. And right in the middle of all that, clinicians have to pull off some of the most complex procedures in medicine. It's one thing to be a doctor, it's another thing entirely to do it under that kind of pressure. So to even begin to function in an environment like that, you can't just wing it. You need a system, a really clear, simple, priority-based system. And that need led to a huge shift in thinking, one that actually might surprise you. I mean, we all know this, right? From the first time anyone teaches you first aid, it's drilled into your head. A, B, C. Airway, breathing, circulation. It's the absolute bedrock. Well, here's the thing. After years and years of real-world trauma care, we learned something huge. For a patient who is bleeding, I mean really bleeding, that order is just plain wrong. In fact, sticking to the old ABCs could be a fatal mistake. And that's what led to this, a new letter at the very front of the line, a big C for catastrophic. So now the approach is CABC, and that means stopping massive, life-ending bleeding is job number 1, before anything else. And it's no exaggeration to say this one simple change has saved an incredible number of lives, everywhere from battlefields to highways. So here's what the whole modern approach looks like. You can see it right there. Number 1, before you even glance at the airway, is controlling that catastrophic hemorrhage. Why? It's simple, really. Bleeding to death is the number 1 way people die from trauma when they could have been saved. Think about it. You can have a perfectly clear airway, but if there's no blood to carry oxygen, it doesn't matter. So you stop the bleed, then you move on to A, B, C, and the rest. And these are the tools that make that C step actually possible. We're talking about things like the Combat Application Tourniquet, the CAT. You can slap that on a limb and stop a massive bleed in seconds. Or these special hemostatic bandages that have stuff in them to make the blood clot super fast, and you pack them right into the wound. These are the game changers that let crews do this out in the field. All right, so you've got the massive bleeding under control. Now you can move on to A for airway. And for the sickest of the sick, this is where things get really advanced. This is where you basically bring an entire anesthetic procedure right to the crash scene. The official name for it is Prehospital Emergency Anesthesia, or PHEA, and it is the absolute gold standard for taking over a patient's airway. I mean, we are talking about putting someone completely to sleep, medically paralyzing them, and then putting a breathing tube right down into their windpipe, all of this right there on the side of the road. So who actually needs something this extreme? Well, the reasons are really specific. You do it for a patient whose airway is blocked, or you can see it's about to be, or for someone who just can't get their oxygen levels up. A big one, though, is a severe head injury. When someone with a head injury gets agitated, it can be incredibly dangerous. And a low level of consciousness, what we measure with something called the Glasgow Coma Score, if that's below 8, it's a major red flag. PHEA just lets the medical team take complete control of everything.
Okay, but how do you do this safely in all that chaos we talked about? You have to create order. And this is how. It's called a kit dump. Every single piece of equipment, every drug, every device is laid out in the exact same way every single time. So the whole team knows exactly where to find everything, instantly. It's like creating a perfectly organized operating room right there on the grass.
And they've borrowed another brilliant idea from the world of aviation: checklists. Before a single drug is given, the team stops and goes through a checklist, out loud, a challenge and response. Who's doing what? Is the equipment ready? Are the drug doses right? They confirm their main plan, and just as important, they confirm their backup plan in case things get tricky. It sounds simple, but this kind of discipline has slashed complication rates, making it almost as safe as doing it in the hospital.
And here's another genius move to make things safer. You design the system to prevent human error. Look at this. It's so simple, but it's brilliant. Color-coded syringes. When it's dark and you're under immense pressure, grabbing the wrong drug could be a disaster. So you make sure certain drugs are always in a certain color syringe. It's an instant visual check that adds this huge layer of safety.
When it comes to PHE, there's really one main goal that everything is focused on: success on the first try. That's it. Because every time you have to try again to get that breathing tube in, the risks go up. Oxygen levels drop, you can damage the airway. So everything, and I mean everything, how the patient is positioned, the gear, the drugs, the team, it's all laser focused on getting it right on that first attempt.
And this quote here really just nails it. It says that making this procedure safe isn't about some lone wolf hero doctor. No way. It's about the team, a team that works together seamlessly. It's about having the discipline to stick to those checklists. And it's about looking at every single case afterwards to see what went right, what could be better, always learning, always improving.
So, when you step back and look at all of this, the switch to ABCs, all this incredible detailed prep for doing anesthesia outside the hospital, what you're really seeing is a total change in how we think about pre-hospital care.
You know, for years, the idea was just scoop and run. Just grab the patient, throw him in the back of the ambulance, and drive as fast as you can to the hospital. But that's all changed. The whole philosophy now is about bringing the hospital to the patient. It's this understanding that for the really, really badly injured, the things that will save their life have to happen in those first critical minutes, right there on scene. It's not just about getting there fast, it's about getting the right treatment started right then and there. And when you think about it, this whole revolution really makes you wonder, doesn't it? I mean, if we can safely do a full-blown anesthetic on the side of a highway, what's next? And people are already pushing that boundary. We're seeing things like blood transfusions, portable ultrasound, even advanced surgical techniques to stop internal bleeding, all happening before the patient even leaves the scene. So it leaves us with this big question: what other parts of the hospital can we and should we start bringing to the patient?
And that's a wrap on our breakdown. Everything we've talked about is based on the article Pre-Hospital Management of the Airway and Trauma from Mockridge and Turner, which you can find in BJA Education. Thanks so much for joining me.